am very excited for this next panel. If you think about the journey we've had today, we've shared kind of what the Secretary has been able to share his vision for our next year. We've had some great insights to some of the projects that we've been able to work on, and we've now moved into kind of seeing what's possible. And now I'd like us to kind of turn our head to 2021. I think we're all looking forward to a new year. And these next two panelists, or this next panel, is really going to cover some of the things that are happening and are going to happen over the next year. So we thought we'd share that with you. It's my great pleasure to introduce Monisha Avery. You saw her in one of our CDII videos earlier. She's our Deputy Director of Service Integration and Stakeholder Engagement. Monisha has a long history of public service and nonprofit work, including 18 years in state service. Prior to state service, she worked in various capacities as a social worker, which included foster care, adoptions, medical social work, and victim and witness service advocate with Sacramento County District Attorney's Office. She received her master's in social work from the California State University in Sacramento. Monisha, welcome and enjoy your panel.
Thank you, John. Hello, everyone, and welcome back from the break. This portion of the webinar provides an example of how data is used to address agencies' priorities concerning health equity and disaster readiness. There's a lot to be covered by our next three speakers, so I'm just going to jump right in. Our first speaker is Dr. Devika Bhushan. She is an equity-focused pediatrician who serves as the inaugural Chief Health Officer of the Office of the Surgeon General. Dr. Bhushan trained at Harvard Medical School and Johns Hopkins and was previously a clinical faculty member at the Stanford Pediatrics, where she pursued research training in health policy and gender-based health equity. She has experience in adversity and resilience, brain health, gender, health equity, and policy analysis. Dr. Bhushan will be speaking on the Adverse Childhood Experience study called ACEs. Dr. Bhushan?
Thank you so much, Monisha. Good morning, everybody. My name is Devika Bhushan, and it's fantastic today to see CDII launch. And what a wonderful series of talks so far. I'm really pleased to join in and be with you guys all today. Today, I'll be sharing with you the Office of the California Surgeon General's strategic vision and data planning around measuring efforts to mitigate childhood adversity and toxic stress. Next slide, please. To begin with, I'd just like to take a moment to orient you to the fact that our State Surgeon General's office is the newest kid on the block, so to speak. It was founded by executive order in 2019. And together, Governor Newsom and California Surgeon General Dr. Burke Harris decided on three top priorities for the office, listed here: health equity, the early childhood period, and what we're going to talk about today, adverse childhood experiences and toxic stress. Next slide, please. So ACEs, as we call adverse childhood experiences and toxic stress, are a public health crisis. They represent a root cause to some of the most harmful, persistent, and expensive challenges that we face as a society. And our office has set the bold goal of working to reduce the impact of ACEs and toxic stress in half in one generation. Next slide, please. When we use the term ACEs, what you're seeing here are the 10 categories of childhood adversities that we reference specifically by that name. This was studied by Kaiser Permanente and the CDC in the 90s. And a series of 10 experiences that you see laid out here were established as being causally related to the toxic stress response, which we'll talk about. And these ACEs include 3 kinds of child abuse, 2 kinds of child neglect, and 5 types of household challenges, which include growing up with a household member who is using substances, has untreated mental illness, or is incarcerated. Next slide, please. What we know is that ACEs are very common. So based on California data from a telephone survey called the Behavioral Risk Factor Surveillance System, this here combines results from 4 different years, from 2011 to 2017. What we can readily see is that ACEs are very common. So just over 6 in 10 Californians, so the majority of us, have experienced at least one ACE. And then about 1 in 6 have experienced 4 or more ACEs before the age of 18. And this is important because ACEs have a dose-dependent impact on poorer health and social outcomes. So in other words, the more ACEs a person experiences, the stronger their risk for adverse outcomes across the life course. What we also know to be true is that because of social and structural inequities, the odds of experiencing ACEs are actually not equally distributed in the population. So what you can see on the left is that residents of more poor and more rural counties in California on average experience higher ACEs. So darker red will represent higher scores. On the right, if you focus on the yellow sliver of these pie graphs, which represents those individuals having 4 or more ACEs, we can see that Black, Latinx, and American Indian and Alaska Native individuals experience more ACEs than either Asian or white Americans. And we also know that ACEs more commonly afflict individuals who are non-high school graduates, unemployed or unable to work in lower income brackets, uninsured or on public insurance, justice system involved women as compared to men, and those who identify as lesbian, gay, bisexual, or transgender. Therefore, working to reduce ACEs is necessarily a health equity issue. Next slide, please. We know that ACEs are associated, I'm actually missing one slide, but I'll talk you guys through it. We know that ACEs are associated in a dose response fashion with 9 out of 10 of the leading causes of death in the country. And they're also associated with almost 50 what we call ACE-associated health conditions. These are pediatric and adult onset acute and chronic conditions that range from heart disease to suicide. There's also a number of adverse educational and social outcomes that are predicted by ACEs, which include learning and behavior problems, high school non-completion, unemployment, poverty, homelessness, arrest, and felony charges. Many of these are vectors for the intergenerational transmission of adversity. When untreated, what we can see on this slide that you're looking at now is that the systems level cost impacts of ACEs and toxic stress are huge. So looking at the left, considering just 8 ACE-associated health conditions listed out here, the health costs of ACEs to the state of California in 1 year totaled $112.5 billion. This combines personal healthcare spending costs with the years of productive life lost due to early death and disability from just these 8 ACE-associated health conditions. On the right, what you can see is a different study that looked at the impact of cases of substantiated child abuse and neglect. So again, that's about 5 of 10 of the ACEs, and found that in the state of California in 1 year, the impacts associated with those cases totaled $19.3 billion across the diverse sectors shown here. Next slide, please. So all of the impacts associated with ACEs essentially occur because ACEs can lead to a health condition known as the toxic stress response. This describes the way in which the brain and the body can encode high levels of childhood adversity in the absence of sufficient buffering protections in the form of safe, stable, nurturing relationships and environments in childhood. So toxic stress refers to long-term disruptions to brain structure and function, to hormonal axes, to the way that the immune and metabolic systems function, as well as to shortening of regions of DNA called telomeres. And shorter length of telomeres is associated with accelerated aging and earlier death. These impacts are encoded via epigenetic changes or changes in the way that genes are read and transcribed in response to the environment. These changes are recognized to be passed from generation to generation. And what we also strongly know, the corollary to all of what I've just talked about, is that ACEs don't have to lead to toxic stress. So not only can early detection of risk and the use of evidence-based interventions prevent ACEs from leading to toxic stress, but once toxic stress is in place, they can actually also mitigate its impacts. And so there's a huge mandate to learn to recognize and to treat toxic stress in healthcare. Next slide, please. In other words, toxic stress is a health condition that's amenable to treatment. This is the central premise of our statewide ACEs Aware initiative, which we'll talk about in just a minute. Next slide, please. The interventions shown on this wheel are all proven in high quality studies to reverse all of the biological changes involved in the toxic stress response. So these are supportive relationships, buffering high quality sleep, balanced nutrition, physical activity, mindfulness practices, nature, and mental and behavioral health care. Next slide, please. So our office, in partnership with the Department of Healthcare Services, has launched a statewide program called the ACEs Aware Initiative. This launched about a year ago, and it really seeks to systematically screen and respond to toxic stress in the healthcare setting, starting with Medi-Cal recipients and using a reimbursement mechanism. The goal is to transform the way in which the healthcare sector operates and the way in which it really recognizes and treats toxic stress as the root cause of multiple chronic diseases. More information about our program can be found at acesaware.org, which also hosts a free online 2-hour training for providers to provide that basic foundation for how it is they can begin to integrate an understanding of toxic stress into clinical management. To date, we've had almost 16,000 providers across the state of California trained. On the right of this slide, what you can see is the kinds of providers who are represented in that training process and where they're located. We additionally have in place about 150 grants out to 100 organizations to really deepen provider engagement, education, and communications opportunities in this area. Another centerpiece of our initiative is the CalQuick. So this is the California ACEs Learning and Quality Improvement Collaborative. It's housed at UCSF with partners at RAND and the Center for Care Innovations. They're generating very deep qualitative and quantitative insights from speaking to and analyzing data from patients and providers who are engaging in ACEs screening and response work for the very first time. They're doing this at 53 clinical sites in 7 regions of California over a period of 18 months. And as an initiative, we're also in the process of issuing grants to establish robust, what we're calling networks of care. And these are locally responsive referral and response systems for responding to clinical risk of toxic stress. Next slide, please. Over the next 3 to 5 years, we're also going to be launching a multi-pronged evaluation strategy for ACEs Aware. It'll really combine inputs from 3 different buckets. The first one being CalQuick, which you've heard a little bit about already. The idea here is that CalQuick is distilling best clinical practices in toxic stress response that drive improved healthcare outcomes, and crucially also an understanding of how to avoid unintended consequences in responding to ACEs and toxic stress. The second bucket of information will come from DHCS. So we're collecting Medi-Cal claims data continuously and reporting it quarterly to enable an understanding of the characteristics of the patient screened and the providers doing the screening, generating insights like the incidence and prevalence of ACE score by, for instance, patient demographics, region, delivery system, and provider type. The final piece of this 3 to 5 year program will be an external evaluation for which we're still seeking funding. And it'll combine the above 2 inputs with additional administrative data to really generate lessons about sort of the systems level practice changes that are resulting from this new program. The first set of changes will be around the changes in clinical management based on the risk of toxic stress that providers are discerning for the first time, changes in referral patterns. Second, we're going to be looking at changes in patient outcomes as a result of having been screened for and treated for toxic stress in clinical care, including rates and severity of ACE-associated health conditions, their associated mortality and disability. Further, we're going to be looking at healthcare utilization metrics, such as changes in specialty versus primary care use, use of emergency departments, rates of hospitalizations, and use of government and community resources. Furthermore, we're going to be looking at the cost effectiveness and cost benefit associated with some of these changes above. Next slide, please. Finally, though we've spent a lot of time today thinking through the role of the healthcare sector in resolving the risk of responding to toxic stress, we know that no single sector on its own can solve such an entrenched set of issues like childhood adversity. So much more about the role of many other sectors, more on ACEs Aware, more on the evaluation plan that I touched on, can be found in the pages of the first California Surgeon General's report, which was just released last month. Next slide, please. The link to the report appears on this slide, and we really look forward to your partnership in advancing the movement to cut childhood adversity in half in a generation. Thank you all so much for your kind attention, and thanks to the organizers of the Data Expo for the opportunity to share our work.
Yes, thank you, Dr. Bhushan. This is no time like now is it important to have the Office of the Surgeon General. So we really appreciate you coming on and sharing what your work is, what you're doing there at the office. So thank you very much for that. So I also want to say that CDII is tasked with assisting in the development of departments' dashboards. A data dashboard allows our leaders to see how programs are performing. They help shed light on where there may be gaps in services, populations or regions that are underserved, or in the case of a disaster preparedness, where we need to target assistance. Dashboards are not new, but CDII will help to bring agency-wide standards, improve the ability to access data, and provide a platform to host data for agency and external stakeholders. One of the newest dashboards to hit the scene is the Data Dashboard for Aging, a collaborative effort from the California Department of Aging, California Department of Public Health, and the Let's Get Healthy California project. If you look to the chat box, you'll probably find a link to their dashboard. Our next two speakers will introduce you to two products that were the perfect examples of the work developed through agency in collaboration and partnership with many other state departments. The All Hazards Dashboard, which was proven to be an essential tool during California's fire and pandemic crisis, and the Agency Data Exchange, which provides a platform for data analysis. So our first panelist, Elizabeth Basnett, who serves as Assistant Secretary over Response and Recovery Operations for California Health and Human Services Agency. She has built her career in disaster management over the last 10 years. And Elizabeth Steffensen, who works with CDII as the product owner of the All Hazards Dashboard. She's been with the agency's family for about 5 years. Sorry about that, Elizabeth, including a Department of Rehabilitation and the Office of Innovation. Please.
Good morning, everyone. Huge thank you to John, to Elizabeth, to all the folks here. I'm going to kind of start this out and then turn it over to Elizabeth Steffensen, who's really just been so fantastic and carried this water throughout this crazy year. I think everyone knows the world of disaster management continues to challenge our practices and our capabilities across the state, across our departments, and across all of our offices. I think we're hearing a lot of that today. With these challenges, it's become critical to establish this environment of enhanced collaboration and coordination. And I think this is why we're all here today. How do we build this data culture and this data environment? This past year with COVID, historic wildfires, public safety power shutoffs, it became so clear that the amount of time and manual process did not enable cohesive decision-making and collaboration around a singular understanding. And what I really mean by that is there was a huge cost in man-hours to collate data and to provide a singular picture across this huge geographic state, rural, urban, and then across all of our departments, that data sharing. I think data being immediately out of date, right? This pain point of data being out of date the minute that you receive it. the lack of clarity of exactly what the numbers mean, the way the Department of Social Services might define, you know, a facility versus the Department of Public Health or any of our departments. I think all of these things became clear in the last 12 months as we went through these kind of historic challenges. And so, you know, also being the new kid on the block with John, and so exciting, this launch today, such a huge accomplishment. This initiative to build a dashboard for disaster response really started around the idea of PSPS. And as the year evolved, it became this all hazards dashboard that we have now that Elizabeth is going to walk us through. But I think the metric for success of this dashboard and how we envision it as we've worked through this is to create a space where data feeds that all departments can access in real time for decision making to occur. And we're all operating off of a single understanding of a current situation. So this is really our metric of success as we move forward. I just want to say a huge thank you to CDII in leading this initiative, and all the departments who have already contributed so much and will continue to contribute. And for Elizabeth being our fearless leader and continuing to bring this home. Just all of these efforts directly impact Californians who are experiencing some of the worst moments in their lives. It enables us to get help faster and more efficiently. So I will turn it over to Elizabeth Steffensen to walk us through.
Thank you so much, Liz. And really, from everything that you shared, it's just so clear that dissolving the barriers to readily available, actionable data really is essential for that real-time decision-making for, you know, the health and safety of individuals across California. You know, the solution to this need, as Liz pointed out, is really an emergency management framework that shows the impact of disasters through integrated, accurate data, and which supports operational decisions and resource allocation during emergencies. The All Hazards Dashboard provides at-a-glance overviews and analytics for CHHS departments as a whole, with 4 overarching categories of data: emergency events, vulnerable populations, state licensed facilities, and operational data. The design is intended to eliminate tedious manual reporting processes, and which naturally increases the time that can be spent on assessment and coordination and the development of mitigation strategies. It also focuses on moving data through automated pipelines to keep the information current, so agency and department leaders can always be looking at the same information at the same time. Finally, the dashboard leverages the Agency Data Exchange, a platform which supports the development of agency-wide data assets and brings unique opportunities for data transformation and analytics. In the next slide, I'll go ahead and share a little bit about our journey. The process of building the All Hazards Dashboard starts with integrated and operational data. Integrated data describes what exists across departments rather than only within a department. So for example, when you look at facilities, you typically have a list of those that are licensed by CDPH, by DSS, and so on. But with disaster management, you need to see whole communities, not just specific slices. So an integrated facilities data set helps to show the cumulative impact and nearby resources during a disaster. The other half of this, the operational data, is essentially the current state of what exists. It can fluctuate from one moment to another. For example, if a healthcare facility needs to evacuate, we'd want to know when the evacuation began, when it's complete, how many beds are available in nearby facilities, at what level of care, and whether they have any urgent needs. Operational data can include many different kinds of inputs, which would be selected based on the setting and the emergency. By developing integrated data sets and supplementing those with operational data, we can see the whole picture of what's happening right now and make emergency decisions accordingly. Sort of taking this into our work with the All Hazards Dashboard, we've learned that both of these kinds of data come with challenges. We really began working toward an integrated facilities data set, which is the cornerstone of the dashboard, and learned that it's simply more complex than we originally expected. So what I'd like to share with you is some of what we learned along the way, as well as things to keep in mind when we're communicating about or developing integrated data. Our takeaways can be boiled down to 3 things. What do you need to know? What does the data mean? And how will the data be used? So first, what do you need to know? The work that we do here at the state is so complex and so far-reaching that it means in part that different questions will get you different answers. So take the 2 following questions. How many facilities are licensed? How many facilities are there? These 2 questions produced 2 answers with significantly different results. And why would that be? Well, we learned that some facilities are licensed, some are certified, and some are both certified and licensed. By asking a very specific question, we inadvertently focused on only a portion of the whole picture. So what we learned is that it's critical to stay in communication long enough to know and ensure that we're all clear on what we really need to know. Our second takeaway, focusing on what the data means. And again, in the world of an integrated facilities data set, what does it mean when we talk about facilities? Are we talking about a license, a building, an address? Though we often think of licenses when we think of facilities, when we started to explore the relationship between licenses and locations, we learned that there are cases in which a single location could hold multiple licenses, and other cases in which a single license could cover multiple locations. And this varies by department. It meant that we needed to shift how we were thinking about and defining facilities. And our lesson learned is that at the most basic level, when we talk about a data element, we need to really understand what that data means. Last, it's important to know how the data will be used. This is, I think, a really critical question to developing a really, truly useful, versatile data set. As we increase our understanding of how data would be used in emergency situations, we've seen more and more opportunities to collect or develop metadata that could make all the difference for narrowing down a truly huge amount of information to quickly highlight priorities. So for example, knowing what facilities have mandated backup requirements for power can help focus attention on the facilities that are in greatest need during a public safety power shutoff. Or knowing which facilities provide services that are critical to life or health can help ensure that critical needs are supported during an evacuation. Even knowing what types of facilities operate on a daytime or a 24-hour basis can help focus efforts depending on the time of day a disaster strikes. With so much data available, it's just essential to be able to understand how it will be used, to see ways to use the data to drive action. So on the next slide, let's talk about how this data actually moves. I want to share with you how data is moved from the source to the visualization. So we're leveraging the Agency Data Exchange, or the ADE, and building automated data pipelines so information moves through as quickly as it's refreshed, keeping the All Hazards dashboard as current as the departments that own the data. I want to pause here for a moment and give just a little background on the Agency Data Exchange. So the whole point of the Agency Data Exchange is to make it easier to share data. It's essentially a cluster of databases within a platform, which allows each department's data to be maintained under separate ownership, but can be selectively shared with appropriate permissions from the data owner. The Agency Data Exchange can serve as a single point of entry for data requests and data sharing, whether that data is being shared within CHHS departments or with external partners, and whether it's being used for a dashboard or research or linkage. It also allows us to build data assets like the Integrated Facilities Dataset, which can then be reused for a variety of data efforts on any data visualization platform. The Agency Data Exchange has huge potential to serve a variety of data needs as the development of this platform continues. In the near future, the CDII data and engineering team will be sharing more about this resource. So definitely keep an eye out for that announcement. Going back to All Hazards Dashboard, what you see here on the screen is that the data begins at the source and moves through an automated data pipeline into the agency data exchange. There, the dashboard has its own separate database, which contains only the data that feeds into the dashboard. This database will ultimately include the facility and population data shared by departments, public reference data like census data, information about emergency events, as well as operational data as we develop those sources. By bringing all of the dashboard data together, we're able to keep an ongoing record of disasters across the state and across time. Eventually, that will mean we can go back and see trends and analyze impacts for even more effective risk assessments, mitigation strategies, and predictive analytics. Here in the last leg of the journey, you see another automated data pipeline that goes from the agency data exchange into the dashboard platform. The All Hazards Dashboard leverages Esri technology, ArcGIS Online, but it's helpful to know that by maintaining the data in the agency data exchange, we can reuse that or any portion of it on other platforms as well. So let's check it out. Next slide. We have here the initial concept for the All Hazards Dashboard, just a couple of screenshots. And while we expect the finished product to look a bit different, there are some really important features that are shown here that I wanted to quickly review. So the point of the All Hazards Dashboard is to really provide at-a-glance overviews of disasters and their impacts, while also allowing users to dive deeper into the data itself. Some of the core features will be disaster-specific data for public safety power shutoff events, which you see on the left, or PSPS, wildfires, which you see on the right, earthquakes and mudslides as well. It'll have a statewide overview of the facilities and populations impacted, as well as the department-specific impacts, needs, and resources. It will provide information on evacuation and shelters and the rates of change for key data sets. The last thing I'd want to note at this time is that the facilities and populations and operational data that's shown will vary by the type of emergency to help ensure that the focus is where it's needed the most. On our last slide, let's talk really briefly about the timeline here. This is a work in progress, and we are aiming to have rollout of version 1 of the All Hazards Dashboard in April of 2021. Between now and then, we're continuing development on data automation, collection of data elements, and front-end design. We'll also have testing in March in the form of a tabletop exercise for validation and feedback. The first release of the dashboard will be ready and available for use by agency and department leaders during emergencies, but we'll be continuing development on additional features and data sets and functionality for future releases. In closing, I really want to take a moment to thank Elizabeth Basnett and John Ohanian for their vision and leadership in this effort, and for the design and development team for really leaning into this project. I also want to especially acknowledge and thank each of the departments who spent time and effort working with us to build these foundational data sets. You really are what makes this type of work possible, and it's truly an honor to work with you. Thank you.
All right, thank you, Elizabeth, both Elizabeths. And I just want to say there's been a little bit of a chat in the chat room, and some suggestion that maybe, I know we're a little bit over time, but if I can, I just want to ask real quickly of Dr. Bhushan, what are some of the open research questions left to answer in the world of ACEs and toxic stress?
Thanks, Monisha. So one of these, potential next areas was actually touched on by one of the attendees in asking the question about how we assess clinically for risk of toxic stress. And admittedly, right now, we have a very blunt clinical tool, which is essentially combining an ACE score, which is the number of experiences you've had out of those 10 that we discussed, plus your presence of ACE-associated health conditions, which then informs risk of clinical toxic stress. But admittedly, we know there's a lot of individual heterogeneity in the way in which people experience ACEs and respond to those ACEs clinically and biologically to create health risk. And so eventually what we want to see is the development of clinically useful biomarkers to define toxic stress very specifically so that we can diagnose it and follow it in response to certain interventions as time goes on. And those are under development. Additionally, we need specific guidelines for the clinical management of ACE-associated health conditions in the setting of, let's say, high, intermediate, or low toxic stress. Identification of potential therapeutic biomarkers for regulating the toxic stress response beyond the impact of the 7 behavioral kinds of interventions that we discussed in the presentation. We also need to understand a little bit more precisely how it is that individual differences in biological susceptibility and response work, as well as longitudinal studies on the specific clinical interventions that we can use for toxic stress for specific kinds of subsets of populations, for specific ACE-associated health conditions, and so forth. So there's a lot of work to be done, but it's exciting to have launched the first statewide ACEs response initiative that we've been able to do here in California.
All right, thank you. And Elizabeth, I just wanted to say you provided a lot of information on the All Hazards dashboard and the data exchange. And my understanding is that there is more to come, that there will be much more discussion around both of those tools in the coming weeks and months. So we will look forward to seeing you, along with maybe some the other CDII folks, David Sanabria and other folks that are working on those products. So thank you for that. And I know I'm a little bit over, so I'm going to go ahead and turn this back over to John. Thank you, guys.
Excellent. Thank you, Monisha. Thank you, Elizabeth and Dr. Bhushan. We've hit the time and we're at this point, but I want to build on what was just being talked about. Is our goal for this expo, we could have spent an hour and a half on each one of these presentations. And our goal was really to give you a broad stroke of things that are going on and things that might interest you. Our goal was to have you engage and let us know what you want more of, where your questions are. And our goal is to kick off a speaker series and webinars and other learning venues for this community that we're creating and building upon. So that's really our goal. Our goal is to hear from you of what you want more on. As we mentioned, we'll be digging into a deeper dive on the agency data exchange and other programs that you've heard here, the speakers that you've heard here. Catch my words towards the end. The one other thing I wanted to mention is, as we've brought up CDII over the last 9 months, it's really been to the eye of what we're going to be. But during a pandemic, I'm just extremely grateful to the team during this time to have been able to stand up CDII, to have been able to respond to some of these projects like the All Hazards dashboard. And what we're looking ahead towards is also looking at what other things we can bring forward. The Office of Innovation, which is also a part of CDII, we are looking in the spring to see what that next look will be with now having an Office of Digital Innovation at the state level, how we partner with that group, how do we become more virtual with our learning. One of the greatest strengths, I think, on the team is our individuals that have been through our innovation office and have gotten trained on human-centered design. And so how can we bring those to the data world at the state? So with that, I would really just like to thank all of you for being a part of it. Please reach out. I'm happy to hear from you and would love to help create products and programs that will be beneficial to the community here. Thank you very much to our speakers and to all of you.